Bismillahirrahmanirrahim. So today in this section we will be talking about chest trauma. And Dr. Talat Waseem, I'm one of the surgeon here. So there can be many injuries following trauma to the chest of the patient. The injuries can be either to the bones, to the lungs, to the heart, to the diaphragm, and the great vessels as well. The bones which are usually involved are usually the ribs. Very infrequently it can be scapula or sternum. Frequently it can be clavicle, but the scapula, first two ribs, and the sternum are very less likely to have a fracture. The lungs can have different types of injuries. The patient can have pneumothorax, a combination of both, lung contusions, or any tracheobronchial tree injury involving the rupture of the trachea or bronchus, leading to massive surgical emphysema. It can also cause injuries to the heart. The very severe injuries to the heart will lead to immediate death, and the patient are less likely to reach to the hospital. But if there are smaller injuries and if there is a bleeding inside the pericardial cavity, that can lead to cardiac tamponade. And the cardiac tamponade will eventually have hemodynamic failure. The tracheal injuries can cause massive respiratory embarrassment and surgical emphysema formation. There can be injuries to the big vessels like ascending thoracic aorta, aortic arch, or subclavian vessels, and there can be aortic or the vascular dissection, which again can lead to a hemodynamic compromise. If there is a rupture, then there will be massive bleeding inside the thoracic cavity and the patient will die immediately. However, if there is a aortic dissection, that can give you some time. So there can be multiple injuries, and one of them is the injury to the ribs. Rib fractures are very common. You can see on this x-ray there are multiple ribs are fractured on the left side of the chest. Apart from the rib fractures, what you need to look is the heart and the lungs. Rib fractures can be often associated with pneumothorax, hemothorax, or a combination of both. If they are associated with hemopneumothorax, then the management of hemopneumothorax would be also required apart from the management of the rib fractures. If there is a pulmonary contusion, then the patient may require some sort of ventilatory support at some point. So it is very important for you to know that the rib fractures alone usually do not occur. They are associated with multiple other injuries, and likely there are pulmonary contusions. So such patients should not be discharged. The patients usually have milder pain at the time of the presentation, or moderate pain, or if there are multiple reflections, then the patient may have severe pain. These patients are admitted, they are observed, they are investigated to rule out pneumothorax or other concomitant injuries, and they are managed with adequate analgesia. To prevent chest infection, as the patient has the pain, the patient moves the chest less often and expectorates inadequately, leading to retention of the secretions within the lungs. When there are secretions within the lung, then there are higher chances of chest infection or pneumonia. So such patients uh, can deteriorate over a period of time when they arrive into the hospital. So these patients should be admitted, preferably in a high dependency unit, and should be observed for any delayed hemopneumothorax. These patients are periodically reviewed, and periodic X-rays may be required to see if there is delayed formation of lung contusion or hemopneumothorax. The patient's vitals are monitored, and the patient's adequate analgesia is administered. Sometimes the rib fractures in more than two ribs at multiple parts leads to a flail chest segment. Flail is an independent chest wall segment which moves against the respiratory pattern. So if there is inspiration and if the chest has to expand, this segment goes in, caves in, and if on expiration, if it has to go in, that bulges out. This is called flail chest. Flail chests with many rib fractures usually are associated with lung contusions. If there are lung contusions, then they have to be treated more seriously in more specialized care, that is high dependency unit or surgical ICU. So you need to do an X-ray chest and to rule out any hemopneumothorax. If there is association of the hemopneumothorax or any other pathology, then it has to be treated accordingly. For pneumohemothorax, you need to put in chest tube. For the lung contusions, oxygen therapy may be required, and these patients may require mechanical ventilation if the patient is unable to breathe adequately or oxygenate adequately. So flail chest is one of the pathologies which needs to be dealt more seriously. Sometimes following the trauma can be of two types. One is the blunt chest trauma, mostly which occurs in the road traffic accident, or it can be a penetrating trauma. If it is a blunt chest trauma or penetrating chest trauma, that can lead to pneumothorax or hemothorax, or combination of the both. What happens in pneumothorax is very simple. There is a lung parenchymal injury which leads to movement of the air from the bronchioles and bronchi into the pleural space, which in turn presses on the lungs to cause collapse of the lung. Because of the collapse of the lung, as you can see in this diagram, there is poor oxygenation and the patient saturation drops. The patient will develop tachycardia and can have hypotension if it is associated with tension pneumothorax or associated with massive blood loss here or somewhere else. So in case of pneumothorax, there is accumulation of air within the pleural space which presses on the lungs, and that leads to the collapse of the lung, and eventually patient deoxygenates. If you see on an X-ray, for example, in this X-ray on the left side, you can see there is a collapse of the lung. The arrows mark the collapsed portion of the lung, border of the lung. Just closer to that, you can see the X-ray has become jet black apart from bones, and there are no lung markings present in that area. So the diagnosis of pneumothorax is usually made on absence of lung markings, bronchovascular markings. If the bronchovascular markings are absent, that means the lung has collapsed. That will lead to poor oxygenation of the patient. So in case of pneumothorax, as you can see on this X-ray, the patient would require a chest intubation on the left side. How pneumothorax occurs? There is a small animation video which you will see at the end of this presentation. Sometimes there can be tension pneumothorax. When the simple pneumothorax is associated with shock, then it is called tension pneumothorax. What happens in tension pneumothorax is there is a massive collection of air within the pleural space, which presses on the lungs and the mediastinum and the lung is pushed on the contralateral side. This leads to the pressure on the heart, pressure on the big vessels like superior vena cava and inferior vena cava, and the pressure on the contralateral lung. So the oxygenation becomes even more poorer. So what would happen when there is a pressure on the heart as well as the big vessels? The preload is increased. The neck veins become engorged, raised, JVP is observed. And as there is a loss of the preload, there is a loss of the afterload. And as the afterload increases, decreases, what happens is that the patient goes into the shock. So the patient will be having tachycardia and hypotension, a raised neck vein, raised JVP and distended neck veins. When you percuss the chest will become hyperresonant. When you auscultate, the breath sound will be absent from the affected side. When you palpate the trachea will be deviated on the contralateral side. And there will be reduced breathing movements or chest movements on the affected side. So on clinical examination, if you find these factors and the patient has tachycardia and hypertension, then the patient has a tension pneumothorax. So the tension pneumothorax is a surgical emergency. The patient has to be treated immediately. If there is a facility of portable X-ray, you can perform X-ray, but before that, you have to intervene. And you will have to put a needle in the second or fifth intercostal space to remove some of the air so that this pneumothorax is converted into a simple pneumothorax rather the tension pneumothorax. As soon as the air goes out, the patient's tachycardia partially settles and the blood pressure improves because of the improvement in the heart function. So the tension pneumothorax is a surgical emergency. If the patient has, it has to be diagnosed clinically. You should not wait for the X-rays and other investigations. It has to be treated immediately. If the patient has the availability of chest intubation, then the chest intubation can be performed right away. So needle thoracostomy is the answer, followed by the chest intubation. A brief animation of the tension pneumothorax will be seen at the end of this lecture. Now, needle thoracostomy is usually performed in the second intercostal space and mid-clavicular line, or in the recent guidelines, it has been proposed to put the needle in the fifth intercostal space in the mid-axillary line. Gush of air comes out, which confirms the diagnosis, and the patient's condition gradually improves, and this gives you time to insert a chest tube. A brief video of needle thoracostomy is provided here, and you will see at the end of this lecture. The chest intubation is performed in the fifth intercostal space in mid-axillary line in the triangle of safety. The triangle of safety is bound interiorly by pectoralis major, posterior by latissimus dorsi, and inferiorly by the nipple line. And when the chest tube is inserted, it is either inserted in upward direction or in the downward direction. If it is inserted in the upward direction, it is usually done for the pneumothorax, and for pneumothorax, a combination of the both usually is directed downwards, and it is attached to the underwater sea, so that the air can go out, but it cannot come back into the pleural space. Here is the chest intubation, it has probably done for the blunt chest trauma on the left side of the chest, and there is a blood inside the tube, which means that the patient had pneumothorax or combination of the both. So either it is a hemothorax or a combination of pneumothorax for which the chest intubation has been done in this particular patient. How the chest tube is done, you will see at the end of this lecture. Sometimes the patient can have massive pneumothorax. In case of massive pneumothorax, what you see is there is a fluid on the right side of the cavity, it's covering completely. In those circumstances, you will have to perform a chest intubation on the right side in this particular patient. So if there is a hemothorax is massive, that is more than 1.5 liters at the time of insertion of the chest tube, then it means that there is a massive bleeding from some big vessel. In those circumstances, you may have to perform a thoracotomy, and you may have to either repair a big vessel or you have to repair a vessel which is bleeding and that is less important, like intercostal vessels. So the intercostal vessels are usually ligated if they are bleeding, but if there is a bleeding from IVC, inferior vena cava, superior vena cava, or some other or heart, then you will have to repair it. So the important vessels are repaired, the less important can be ligated. If there is a bleeding less than 150 ml or something like that, then you can continue with the chest intubation, and the chest intubation alone will look after it. But if there is a regular increase or there is a gradual loss of the blood of like 200 ml per hour, then it means there is a ongoing loss of the blood from some big vessel. In those circumstances, you may have to perform thoracotomy. And after performing the thoracotomy, which is opening up of the chest, you will have to ligate the bleeding vessel. Sometimes the patient can present with a shock. Cardiac tamponade happens because of accumulation of the blood within the pericardium that compresses on the heart, and the afterload dramatically decreases. So the patient goes into the shock. Because of the back pressure, patient develops engorged neck veins. It has to be differentiated from the tension pneumothorax. Number one, in case of tension pneumothorax, there will be hyperresonant chest on one or both sides. The trachea will be deviated to the contralateral side, and the breath sounds will be absent on one or both sides of the chest. However, in cardiac tamponade, there will be the similar findings like raised JVP, and the patient will be in shock. However, on auscultation, the breath sounds will be present on both sides, and the heart sounds will be muffled, which is called Beck's triad. So if the patient has a shock, a raised JVP, and muffled heart sound, then it is diagnosed as cardiac tamponade. If there is a cardiac tamponade, that also has to be diagnosed clinically. And if so, you will have to perform pericardiocentesis, that is through the needle removal of the blood from the pericardium. If it helps, it's okay. If it does not, and that blood has clotted in the pericardium, then in those circumstances, it would be wiser to perform a thoracotomy or a sternotomy, and you will have to take out the blood from the pericardium for the betterment of the patient. There will be a brief animation at the end of this lecture to show how cardiac tamponade happens. There is another pathology called subcutaneous emphysema. Sometimes what happens is that the air leaks from the pleural cavity through the chest wall into the subcutaneous space. And if you see in an X-ray, there is the air within the chest wall, within the subcutaneous spleen. If you palpate such patient, the patient feels like having crepitus in the chest wall. That can occur either due to the injury to the lung, or the trachea, or bronchus, or esophagus. Mostly that is the injury to the lungs, and it is usually associated with pneumothorax. If it is associated with pneumothorax, then you will have to put in a chest tube. But if it is not associated with pneumothorax, then it has to be treated either conservatively, or if there is a massive surgical emphysema and there is a rent in the trachea or bronchus, then in those circumstances you will have to perform thoracotomy, and you will have to repair the lesion physically to save the patient. So for subcutaneous emphysema, usually it is treated conservatively. If it is associated with pneumothorax, then chest intubation is the answer. If there is a massive injury of the trachea or bronchus, then in those circumstances, you will have to perform a thoracotomy, and you will have to repair the trachea or bronchus wherever the injury is. Sometimes, in case of high velocity chest trauma, they can be due to either sternum, first to ribs, or scapula as well. However, you can find another important finding on the chest X-ray, and that is the voidant mediastinum, as you can see in this X-ray. When the mediastinum is voidant, it means there is some sort of injury to the big vessels of the chest, which are not bleeding at the moment, but they will bleed at some point, and they can cause hemodynamic compromise. So in such patients, you cannot discharge the patient whether the patient is hemodynamically stable or unstable. You will have to ensure that the patient undergoes a CT angiogram, and provided the patient is hemodynamically stable, and you will have to see whether the patient has some aortic dissection or some injury which is incipient at the moment. And if there is vessel injury, then you will have to involve the thoracic surgery department, and they will look after the chest and the vascular injury to the big vessels.
In open pneumothorax, a wound creates an open passage between the external environment and the pleural cavity. Air can potentially pass in and out of the chest cavity through the hole in the chest. With the loss of negative pressure in the pleural space, which would normally hold the lung in an expanded state, the lung on the affected side will now collapse. With inspiration, the rib cage will expand and the diaphragm flattens, but the negative pressure may now pull air into the chest cavity through the hole in the chest wall. Depending on the size of the wound, the affected lung may partially expand or may remain completely collapsed. The effect of air being drawn in through the hole in the chest has led to the term sucking chest wound, though this movement of air may not always be obvious. Treatment of open pneumothorax involves applying a seal to the chest, which, by means of a valve, will allow blood and air to be expelled during exhalation, allowing a negative pressure to be created and the lung to reinflate. The patented Russell chest seal represents a state-of-the-art dressing designed by leading trauma experts for this specific purpose. It has a valve designed to open with a small positive pressure gradient and with sufficient capacity to allow a high flow of air and fluid to pass through it. 4 apertures allow this to happen efficiently and with minimal risk of obstruction. On inhalation, even a small negative pressure will make the valve close, even in the presence of fluid such as blood.
Welcome to the 456 EMS show for the awake, alert, and disoriented.
Decompressing a tension pneumothorax with a needle chest decompression can be a life-saving procedure. However, there are significant risks if it's not correctly performed. The first step is to take proper infectious disease precautions. Since this is an invasive procedure, a possibility exists for exposure to the patient's blood. The air in the chest cavity may propel potential infectious material toward the medic. The use of gloves, gowns, eye and face protection are recommended. Next, prepare your equipment. At minimum, you will need a 2-inch 14-gauge over-the-needle catheter, 18-gauge for pediatric patients, antiseptic wipes to clean the site, tape to secure the catheter, and a mechanism for creating a one-way valve. Unless you have access to commercial decompression supplies, the simplest way to construct a one-way valve is to insert the IV catheter into the finger of a glove. Additionally, a 10 milliliter syringe filled with 5 milliliters of normal saline attached to the needle may be helpful. This is especially beneficial in a very noisy environment. Identify the location for needle insertion. Remember, a tension pneumothorax may affect breath sounds on both sides of the chest. Be sure you are on the side of the injury. Find the mid-clavicular line on the affected side. Studies have shown that a significant number of healthcare professionals have difficulty locating the mid-clavicular line and actually insert the catheter medial to the ideal location. This poses significant risk if the needle is inserted into the mediastinum. The mid-clavicular line is located midway between the mid-sternal line and the axillary line. To find the second intercostal space, palpate downward until you feel the third rib. The first rib is not palpable since it is behind the clavicle. The space directly above the third rib is the second intercostal space. You may need to apply substantial pressure to feel the ribs on patients with significant soft tissue over the area. Prep the site, then insert the catheter just above the third rib at a 90-degree angle. Once you reach the pleural space, you should hear a hiss as air escapes. Or, if you have attached a saline-filled syringe, you will see bubbles in the fluid. Stop advancing the needle and thread the catheter off until the hub reaches the skin. Remove the needle and secure the catheter with tape. You should note air escaping on exhalation and the glove finger collapsing on inhalation if your one-way valve is working correctly. Observe the patient for improvement. Over time, as air escapes from the thoracic cavity, the patient's respiratory efforts should improve. You may insert additional catheters to speed decompression if your patient's condition warrants. Here are a few more important considerations when performing this procedure. Heavily muscled individuals may require a catheter longer than 2 inches to reach the pleural space. You may use a 3-way stopcock in place of a glove finger, but you will have to open the valve manually to release air on exhalation. Occasionally, the catheter may become obstructed by clotting blood or tissue, so make sure to continuously reassess your patient.
The first step in the placement of a chest tube is to identify the insertion site. The insertion site is the 5th intercostal space just anterior to the mid-axillary line on the affected side. This can be found by using the nipple level as a landmark for the 5th intercostal space. In females, always be aware that the nipple may be displaced inferiorly due to large pendulous breasts. In this case, remember to stay above the inferior mammary fold where the nipple would normally lie. With the patient lying supine, position the hand up and over the ipsilateral shoulder and secure it in this position to keep it out of the surgical field. Surgically prep and drape the chest at the predetermined site of tube insertion. Using a small gauge needle, locally anesthetize the skin and subcutaneous tissue and the periosteum of the underlying rib. If possible, the pleura just past the rib should also be anesthetized. Make a 2 to 3 centimeter transverse incision parallel to the line of the ribs at the predetermined site with a number 11 scalpel. Bluntly dissect the subcutaneous tissue with a scissors or hemostat. Dissect over the top of the underlying rib until the next highest intercostal space is encountered. With the tip of the hemostat, puncture the parietal pleura while pushing just at the top border of the rib. You must always enter the pleural space over the top of the rib to avoid damaging the neurovascular bundle that lies along the groove at the inferior border of each rib. Be sure to enter the pleura in a controlled fashion to avoid lacerating the lung with the hemostat. Once inside the pleura, spread the hemostat widely and withdraw it while still open to create a sufficient opening in the pleura for the chest tube. Before inserting the chest tube, place your finger into the hole of the pleura. Move your finger around 360 degrees to confirm correct location in the pleural space by feeling the lung and making sure that there are no adhesions or impediments to placing the chest tube. A large chest tube, a number 36 or number 40 French, is used in trauma to allow for the evacuation of blood and clots. Clamp the proximal and distal ends of the tube before insertion. The distal clamp will keep any blood from rushing out before it can be connected to a collection chamber. The proximal clamp will assist in chest tube insertion, but may not always be necessary or helpful. Advance the chest tube into the pleural space to the desired length. All of the drainage holes should be well inside the chest cavity to provide a proper seal and prevent leakage. The chest tube should be positioned posteriorly and aimed superiorly in the chest cavity. This will allow for maximum drainage in the supine position. It may be possible to see fogging of the chest tube with expiration, and it may be possible to listen for improved air movement on the affected side. Connect the end of the tube to an underwater seal apparatus collection chamber.